Okay, so I wanted to start out my presentation today by quoting something I thought I heard Catherine DeVries say about 5 years ago. I can't really remember what she said. I can't actually really remember how long ago it was, but let me try and give you the gist of this. So she said, public health needs to stop excluding surgery. This was actually in a public forum in a meeting. I would have liked to have responded, but I was in such shock I couldn't actually find words. She said, it's about time people recognize that surgery is really about public health. And so we're public health in a school of medicine, and if anybody's unfamiliar with that pecking order, we always see, surgery up here and public health way down here, so for somebody to call us out and say we're being exclusionary was a bit of a shock. But I took that seriously once the shock wore off. And the public health establishment sort of would say, well, you've got to talk about the elephant in the room, right? Is it the scalpel or the syringe? How many, I hear this all the time, boy, they did that surgery, but think of how many immunizations they could have done for the cost of that one surgery. And in public health, it always seems to come down to a numbers game. We're trying to see where do we get the best bang for our buck, and is surgery really the place? So I thought, well, maybe that's not really the elephant in the room. Maybe the elephant in the room is the blind man's elephant. And if you look at the last couple of lines, though each was partly in the right, all were in the wrong. And I think we approach health systems this way. Everybody's got their one piece, and they want to say, well, this is the best part of the health system, and we really need to highlight this. I blame public health for the fact that we don't see the elephant very well. I kind of think that's our job. So I want to bring this, a personal story. This is skiing about a week ago with my two brothers, and I'd like to just talk about one of my brothers. So here's Steve. He's a public health professor at the University of Utah. Here's my brother, surgery professor at the University of Texas Southwestern. Genetic similarities, of course, raised in the same household. He's a little better looking than I am. But when you ask my mom what we do, she says, well, he's a surgeon. And they say, well, what does your other son do? Well, he does public health. What is public health? I'm not sure. He does something with computers, and he seems to travel a lot. So we've not done a great job. If you go back to the Welch-Rose report back in 1915, written right after the Flexner report, which really outlined, of course, the Flexner report outlining what we should be doing with medical education. The Welch-Rose report was written a few years later, and the idea was, how do we think about public health education in this same way? And public health education was deemed to need to be independent of medicine. And unfortunately, I think we've done too good of a job of focusing on that independence, and we've forgotten that we need to be interrelated or interdependent. So at the graduation ceremonies at Northwestern, fortunately, the Commissioner of Health for Chicago made that point. The reality is that the health of the individual and the health of the community are interrelated and interdependent. So I think maybe Catherine was onto something. So just as we don't think about bodies as a host of organs that can be sick or not, we sort of think of whole people. We need to think of communities in this way, of course. Communities aren't simply a collection of people, just as bodies simply aren't a collection of parts. And when we think about how to approach things like surgery, how do we think of that in the context of the global situation, and even down to the theme of the conference, how do we think about extreme affordability? And I think what they did with these slides is they have the screen far enough away that I realized this is a very difficult slide to read. So let me tell you what's going on in this slide. This is Yuri Bronfenbrenner's model of ecology, looking at how people fit within the social structure. And in the smallest circle is the individual, and we can even, of course, in health and medicine, go even further down as we refine what we mean when we look at our focus for a particular activity. Sometimes it gets down to a single organ, or even more refined, down to a single gene. But we can think of the individual sitting within a small system of relationships, sitting within a little more distal relationship, sitting within a community or a city or working within an institution, and all sitting within a cultural setting. And of course, Dr. Weisner did a nice job of talking to us about the importance of that. We also have this arrow running along that says these things are dynamic. We can't see them as set at one time, but they're changing over time, and they're changing sometimes very quickly. So it's a very dynamic environment that we're trying to work within. And as we've heard from many of the presentations already, the circumstances and environment under which surgery takes place is something that we have to take into account and think about very seriously. And coming from the public health perspective, this is something that we have to really consider in the whole array of things that we can bring to the health of a population. So Catherine and Ray Price very nicely put this book together. No disclosures here because I get nothing out of it, but they did a very nice book on global health, or global surgery and public health. In some exploration for this book, there was really not much out there talking about surgery from the global or from the public health perspective, and so I applaud them for putting this together and thinking about surgery as this type of a resource. In our division of public health, which if you see, we have a very nice logo system at the University of Utah, given the multiple orientations any one entity within the institution might have. We've done a good job of not making our logos look too NASCAR-ish. But in here, you can see within the School of Medicine, public health sits within a Department of Family and Preventive Medicine. And trying to then help people understand what is the role of public health, we've added the tagline, the community is our patient. We like to think of communities as entities, and how do we keep communities healthy? And if you don't think surgery is a part of that, well, I think you're fooling yourself, because that has to be part of the set of resources we bring together in this type of a situation. Here's an example of some work we're doing in Ghana where we're trying to look at the whole environment in which health takes place. And rather than trying to just do focused and targeted interventions where we're trying to take this issue and that issue, we've really tried to, from a public health perspective, look at the entire environment and context and try to look at this ecologically. And as we think about these types of approaches, we can do our best to make sure that, because I doubt anyone in here who does surgery wants to see a case that really wasn't necessary. They'd prefer to see the cases that are needed. And we already saw that with slides, for instance, from Dr. Muntz, that there are all sorts of needs that aren't being met. So let's not do surgery on things that really are not going to require it if we can prevent it. So let's prevent where we can. Let's use surgery as a strategically deployed resource. So as we think about surgery and public health, and especially in the context of extreme affordability, I think surgery needs to do what surgery does well. That is, develop these approaches, techniques that can be strategically deployed, that are going to be effective and that are going to be cost-effective. And again, much of that follows the theme of what we've already heard about. I think public health needs to embrace responsibility for health systems level thinking much more than it does now. That we need to move beyond some of the traditional roles public health has played, and we need to think about how do we approach populations for optimal health and wellness given the resources that we have available. When we think about framing the future of public health, and right now I'm part of a commission where we're revisiting the Welch-Rose report of 1915, which was largely about sanitary engineering and infectious diseases. And certainly we don't want to forget that those are incredible issues that we would like to take care of as much as possible. But we need to think about integrating resources for optimizing the health of populations. And so one of my pushes on this commission is that's the way we think. And when we think that way, and I put 2015 there because our goal is to have something out for the centennial anniversary of the Welch-Rose report, that clearly we need to think about the whole breadth of health resources that need to be deployed. So maybe it is both the scalpel and the syringe and a whole lot more. And so I'd like to go back to this, that yes, Catherine, you were right. Public surgery is a public health resource, and I think if we work together and can really understand this elephant of health systems better, we can get it to do a whole lot more tricks than we're getting it to do now. As a parting statement, I see Dr. Schechter here. I saw you were emeritus, and we have an opening in public health. You did such a great public health presentation. I'd like to talk about a second career. So, but thank you very much.